Hello, good day, everyone. First of all, I would like to thank Megamind and Megagen for giving me such an opportunity to compete at the Continental Round. And let me take this chance to briefly introduce myself. I'm Dr. Tarek Diwan. I'm a periodontist and implantologist and a lecturer in the field. And I'm originally from Egypt and currently practicing in Doha, Qatar. And today, our topic will be soft tissue architecting in heel sites. So the goal of implant dentistry wasn't only about restoring function and aesthetics, but it's also about how to maintain and sustain both on the long term. And in order to guarantee such result, you have to work on three main zones. The first zone is what we call the implant osseointegration zone, and the second zone is what we call the supragingival restoration zone, while the zone that is completely overlooked by most of the clinicians worldwide is what we call the emergence and the peri-emergence complex tissue zone. So this zone is composed of several variables where if optimized and it will enhance the long-term stability of aesthetics and function. So these variables, once optimized, it will support the long-term functional stability of the implant osseointegration zone by providing the functional and biological tight seal protection around the implant, while at the same time, it will support the long-term aesthetic stability of the supragingival restoration zone by providing the pink architecture framework around the white aesthetics as well. That's why we say that the white aesthetics are only complete when framed by the optimized pink aesthetics, meaning that if you have a single missing component of the, so as we mentioned that the white aesthetics are only the optimized pink aesthetics. So out of a gigantic bone and soft tissue surgery sequence decision map, today we will be talking mainly about the cases of the heel sites, and I will take you through some examples, few examples of how to manage the cases around the heel sites. So we categorize the soft tissue into three main categories. The first one is what we call the thick or adequate biotypes and keratinized tissue with no contour deficiency. The second is what we call the thin biotypes or deficiencies in the labial contour. And the third is the deficiencies in the keratinized tissue and combined deficiencies. So following some surgical soft tissue specific roadmaps, it will help me achieve the best possible function and aesthetic outcomes for the long-term stability as well with the least number of surgeries and the least invasive ones. So out of all the protocols, let's start with the cases of the thick or adequate biotypes and keratinized tissue with no contour deficiencies. And in such cases, we follow what we call the map of contour creation. So we start with no qualitative or quantitative tissue deficiency, and we need to create an emergence profile following the EBC contour concept with a customized healing abutment that will be placed on top of the implant on the same day of the surgical placement or on the second stage procedure using a provisional crown that will help me push back the papillae in place, and as well it will help me support the labial contour and the free gingival margin at the new position. And the advantage of such tissue that with the labial tissue displacement while shaping the tissue, the tissue won't or the shaping won't exceed the quantitative tissue threshold, and it will result in an ideally contoured crown. And that can be done with an edge flap, which is a papillary sparing incision, or an envelope flap that can be done on the first stage implant surgery or on the second stage surgery. So following such protocols on the day of the placement, sparing the papillae, placing the implant in the ideal 3D position, customizing a healing abutment on top of the implant, secured on top of the implant, it will help me in a 3 months time just create the perfect emergence profile and the tissue architecture that is ready for final scans, and then we proceed with the final crowns. And thanks to that kind of tissue, that will help me restore the tissue with the ideally prosthetic contours. Jumping back to the cases of the thin biotypes or deficiencies of the labial tissue contour. I'm sorry, the screen is stuck again. Can you hear me? I'm sorry, screen is stuck. Oh.
Please start.
So in this kind of a category of the thin biotypes, the challenge here is that we have a quantitative tissue deficiency. So if you just try to do exactly the same like what you have done in the previous category, that labial tissue displacement while shaping your emergence profile will exceed the quantitative tissue threshold. And eventually it will result in some recession and a long crown. And that is how we face it in most of our cases with the kind of soft tissue. So this will leave no option for yourself or the dental lab technician compensation, but to do a deformed crown to overcome the shortcoming of the labial deficiency as well. So that is why in such cases we follow what we call the map of contour creation and compensation, where we need to compensate the lost labial volume with a roll flap, modified roll flap, or a free connective tissue graft. And that can be done as well on the first stage implant surgery or even on the second stage surgery. So out of all the techniques, we will be talking today about the cases of the roll flap and some of its modification, where the idea of the roll flap is simply rolling the the crestal connective tissue on top of the ridge towards the labial pouch with some traction sutures. And the main concern here is always the papillae, that we need to spare the papillae in our incision designs, rolling the tissue towards the labial side, placing the implant, customizing a healing abutment on top, and eventually in a 3-month time, you will end up having a very good architecture of the tissue ready for your final crown. But the main problem is that it's not feasible, or it's not doable in all the cases, that to spare the papillae. That's why we modified the technique in a way that we don't spare the papillae in our incision design. We just reflect the tissue and place the implant and place the customized healing abutment on top. And on that labial crestal reflected tissue, we will take 2 vertical incisions, 1 horizontal incision, and as well we will de-epithelialize all that area, roll it towards the labial side here, while at the same time we spare the papillae to reposition them back again in between the or around the customized healing abutment. So in a 3-month time, you will find that your gingival architecture is perfectly ready for the final scans and the final crowns. And thanks to that technique, that will help me restore back the natural prosthetic contours of the crowns based on the soft tissue architecture. So can we do the same technique on the second stage surgery? And can we do it with multiple implant sites? Yes, we still can do. So in such a case, where this case presented to the clinic with the aim of restoring the the missing teeth, so he's having a limited restorative clearance, and as well he's having an uneven deficiency in the labial contour. And this will eventually end up with a very short inclined crowns. And unfortunately, we advised the patient for some orthodontic therapy, but his workplace, they were having some restrictions that the employees can never place any kind of orthodontic appliances. So we had to find a way out. So here as well, as long as the patient was a smoker, so we decided to submerge all the implants, and then on the second stage surgery after healing, we will manage the soft tissue. So we decided to push all this tissue again towards the labial side, to be able to do a proper emergence of the white aesthetics later on with the same open roll flap technique, where we reflected the tissue and we placed some healing abutment on top of the implants. We started drawing on top of the crestal tissue to specify the parts that will be rolled towards the labial side. And from here, after rolling towards the labial side, we have compensated the volume around the implants and around the pontic sites. And now it was time to support that tissue and the pontic sites as well. So we fabricated what we call an interconnected custom healing abutments with ovate pontics that fits on top of the implants on the same day of the second stage surgery. And after a couple of relines and 8 weeks of healing, we have obtained the ideal architecture of the tissue that is ready to receive the final crowns. From there, we fabricated the final bridge on top of the implants and we secured it on top, and it fit really nice with the proper architecture of the tissue, restoring back the natural prosthetic contours. And that was before, during, and after. Okay, let's jump into the next category of the cases of deficiencies in the keratinized tissue and combined deficiencies as well, where actually here the challenge is even higher because it's not only about the quantitative tissue, but also the quality of the tissue. And in such cases, if you try to do exactly the same like we have done in the earlier categories, you will figure out that the tissue threshold, it will exceed the tissue threshold, the qualitative and quantitative tissue threshold, recession will occur, and also implant might be exposed as well. And that is the disadvantage of such tissue. That is why we follow here what we call the map of contour creation, compensation, and correction to correct the labial keratinized quality as well, and can be done as well using several techniques that can be done on the first stage or the second stage surgery. So out of all these techniques, we will be only able today to discuss briefly about the apically displaced flap. So the apically displaced flap is displacing the crestal connective tissue, the crestal keratinized tissue to more labial position or a more apical position. And using this, it will help me as well, having a very good volume of the keratinized tissue on the labial side. But the main disadvantage of such technique that we always lose the height of the interdental papilla in between the implants because we have reflected all the tissue to the more apical position. And that's why we never do this nowadays. We just follow the Palashi modification of the technique. So we just exactly do the same with submerged placements of the implants, and we reflect the whole crestal keratinized tissue. And then we take additional 2 incisions that will help me recreate back all the papillae in between the implants to be rolled and rotated around the neck of all the implants. And the remaining part of that tissue will compensate the future free gingival margins and as well the labial keratinized tissue and volume. So following the same protocol, we created back the papillae back in place, not to lose the vertical volume, secured the papillae back with sutures, and from there in a 3 weeks time, now it's ready for the final shaping the final tissue, scanning and doing the final crowns without any loss of the papillae. And that is why we say that always frame it with the optimized pink. So jumping back again to the thick or adequate biotypes and keratinized tissue with no contour deficiencies, where we had to manage on the second stage. Why did we manage on the second stage? Because sometimes the wisest choice is to let the tissue forget the past, reset itself, and start again from scratch. And that is a typical example of this scenario, where actually when this case presented with such a concern to replace her anterior teeth with implants, we have a damaged anterior teeth, overdeveloped premaxilla, 6 years old provisionals, and a very deep bite. So we started with doing some digital smile design to try to know where exactly our teeth should be located. And accordingly, we transferred this design to the soft tissue to evaluate the quality of the soft tissue or the remaining soft tissue after the trimming. And we find that we have a good tissue volume and quality as well. From there, we decided to focus more with the bone at this stage. We opened the flap, we extracted all the teeth, removed all the infections, and using a prosthetic guide, we started doing some bone scalloping around the implant sites and the pontic sites as well, followed by placing the implants and doing some GBR to restore some of the compromised bone qualities around the implants and pontic sites as well. From there, we allow the tissue to heal in a submerged fashion, and then in a 6-month time, the patient came back and we opened on top of the implants with some crestal incisions to expose the implant, and we start with the shaping phase. So using a provisional bridge, we had to cut a lot of tissue and trim a lot of tissue with some burrs and some diode laser gingivectomies as well. And you can see me highlighting as well the areas that needs to be cut. And from there, we line accordingly the parts of the provisional bridge that will need to shape the tissue. And over a phase of 6 months of shaping, we have finally achieved the perfect architecture of the tissue and fulfilling all the variables of the pink aesthetic framework components around the implants and around the pontic sites as well, finalizing the final framework of the tissue that is ready for the final scans. From there, we took the final impressions and we delivered the final bridge on top of the implants. And that is how it looked on the day of the delivery. You can even notice some still inflammatory spots showing on the soft tissue, and that it just needed much more time to mature. And then the patient disappeared and showed up again in a 20-month. So it was time to check how the tissue have matured so far, and it was time to remove the curtains and check how the tissue is looking right now. And actually the tissue have matured really nicely around the implants and as well around the pontic sites. That is a close-up shot as well, showing you how the tissue maturation and stability as well over time. This is how the patient smiled before, and this is how the patient smiled after, and that is how the tissue looked before and how the tissue looked after. And that is why we say that the white aesthetics are only complete when framed by the optimized pink aesthetics. Finally, my final message to you is those two pictures are both my pencil drawings. The one on the left side is took me 2 hours of drawing, and the one on the right side took me 200 hours of drawing. That's why we say that good things take time, great things take longer. So it's always about the fine details. Thank you you so much and hope you enjoyed the lecture. Thank you.